I think that the reasoning behind this, the practical and clinical reasoning, is that we have a new TKI approved through the TiNivo-3 randomized control trial comparing tivozanib with sorafenib. And tivozanib, the new TKI, was approved and is thought, based on the fact that TiNivo-3 enrolled patients in later lines of therapies, it is thought to be a drug that we can use in later lines of therapies. However, when TiNivo-3 was done, it was years ago when we had different therapy standards. Certainly at MD Anderson, we were treating patients very differently in 2018, 2019 than we do now. And so what we wanted to actually see is, okay, if we take a relevant contemporary cohort with all the biases that a single center academic study done at MD Anderson would have, if we take that and we see what is the efficacy of tivozanib, that will help us position it both for our future clinical practice at MD Anderson and other centers like it. And so what happened was we used a cohort that was heavily pretreated. 30 patients were analyzed, treated with tivozanib, who had received a median number of 4 prior therapies. That's a large number, and it shows again how in the contemporary setting, how many lines of therapies we now have available. All of these patients had received, for example, prior checkpoint inhibitors, and most of them had received some of our strongest TKIs like cabozantinib or lenvatinib. 93% of them had received at least cabozantinib or lenvatinib, and about half of them had actually received both cabozantinib or lenvatinib. So this is very much the scenario where you truly want to see whether using tivozanib will produce these responses, for how long, and to whom. What we ended up seeing pretty much summarized a general impression, both within our group and in other practices, about the behavior of tivozanib in this setting. I think it's fairly representative. And what do I mean? I mean that when we get side effects, because tivozanib is such a focused TKI on targeting the VEGF pathway, we're going to be seeing the type of side effects that are related to inhibiting the VEGF pathway, like hypertension. So half of the patients had, 4 of the patients had any grade hypertension, so 13%. And there were some patients, 6 of them actually, 6 out of the 30, that would have severe hypertension, meaning severe side effects, meaning grade 3 or more, that are related to the cardiovascular system mainly. So it would be hypertension, congestive heart failure, which we noted actually in 3 of these patients, 3 out of 30. And then other things like GI disturbances, even a GI perforation, and mucositis. So no unexpected safety signal was observed. Nothing that we did not expect, nothing that we do not usually observe with other TKIs, let's say like axitinib. And this is good to know. And it is good to know that, for example, because patients on later line therapies, they do tend to be sick. And so it's important to know that if they are sick and older and they have, let's say, congestive heart failure or uncontrolled hypertension, you have to be extra careful. And that can help clinicians actually position tivozanib versus the other agent that was just approved in later line settings, belzutifan. Why? Because belzutifan is not expected to cause to worsen hypertension or worsen congestive heart failure. And it's not also not going to be impacting other potential aspects like the healing of wounds. So these are important things for clinicians to know when they're trying to decide, hey, am I going to give this patient on the salvage later line setting, fourth line or later, belzutifan, or maybe am I going to choose tivozanib? And this is also the reason why in our tivozanib study, we also looked to see what are the characteristics of the patients that benefited the most. Again, with all the caveats of the limitations of the study, if you look at the data, again, most of these patients were heavily pretreated. They had received at least cabozantinib or lenvatinib. And what we saw is that from the 26 patients that we could evaluate their radiologic response, only 2 of them had a confirmed partial response. So none of them had a complete response. So that's an objective response rate of about 8%. And on average, the median progression-free survival was 3.8 months. So on average, when you do decide in this setting to give tivozanib, you probably should not expect that you're going to get deep responses or that they're going to be durable. Now, the patients that did show clinical benefit were the ones that before starting tivozanib were on TKIs for a long period of time. So if, for example, they were on a systemic therapy for anywhere between 2 years to 5 or 6 years, those were the patients that were more likely to benefit. Those are the patients that we can speculate perhaps have had for a while a more anti-VEGF TKI sensitive disease, and that is likely why tivozanib was appeared to produce more benefit in that subset. I really want to give a shout out to Andrew Jones, who is a hematology and oncology fellow at MD Anderson, who led this study and did by far most of the heavy lifting in all of this, because it is through his work that we were able to extract this granular data to get that information under the guidance and mentorship of Nizar Tanir and the other co-authors. And so what I think is that exactly because of the contemporary setting that this study was used, the data from this study came from, we can feel more confident that there is nothing surprising. Like, it's not like, oh, magically tivozanib gives the ability to get a response rate of 40% or 50% or anything like that. You see what I'm saying? Because, you know, I would have been surprised. I would honestly have been surprised if we saw high response rates and a long median PFS in this setting. Again, it's also not surprising to see that the toxicity was primarily cardiovascular in nature. It is also good that we didn't see such surprises in the adverse events. So what the study really adds is it provides more confidence to clinicians who will have to use this. There is no doubt that clinicians in actual practice will be faced with the dilemma. I have a patient that needs a fourth-line therapy or a fifth-line therapy. Should I give tivozanib? And if I do, what am I going to expect? So side effects-wise and response-wise and PFS-wise, they can use this study to get a sense of what to expect, both for the clinicians and the patients.